Welcome back. Angelo and the PCDT shared our starting point for this public meeting and some of the questions we want to explore. And now I'm excited to welcome our first panel discussion. At this time, I ask our panelists to go ahead and turn on video if you haven't done so already. In this session, we have invited 4 esteemed experts to discuss their perspectives on developing a pathway toward the 2030 goal of having all beneficiaries in a care relationship with accountability for quality, outcomes, and TCOC. After each panelist offers a brief overview of their work, I will facilitate the discussion by asking each panelist questions on the topic. The full biographies of our panelists can be found online, along with other materials for today's meeting. I'll briefly introduce each of our guests and give them a few minutes each to introduce themselves. After all 4 introductions, we'll have plenty of time to ask questions and engage in what we hope will be a very robust discussion. So first, we have Dr. Michael McWilliams, who is the Warren Albert Foundation Professor of Healthcare Policy and Professor of Medicine in the Department of Healthcare Policy at Harvard Medical School. Michael, welcome. Please go ahead.
Thanks very much. It's really a pleasure to be with you all today. And before getting on to the substance, I just want to reiterate what's in my disclaimer here, which is that I am here with you today as me, as a professor, and not in my capacity as an advisor to the Innovation Center. If you could just forward to the next slide. So I know the main theme today is participation, but I do want to just level set a bit and note that the goal, the ultimate goal, isn't participation per se. It's we want success, right? And we can debate what success means. But I think it's important for us to talk about participation not as if we've already figured out the payment models entirely and we just sort of need to coax providers into them or help them succeed, although those things are very important, whether that's through temporary participation bonuses or more technical assistance. But I think it's also really important to think about participation as an outcome or marker of sound model design. Because a big reason why we're sort of stuck at 50% participation is that the models have basically been designed in a way that can never be advantageous to more than roughly half of providers, even if all providers are capable of succeeding, of generating savings. So I tend to think about the goal less as sort of reaching 100% participation and more as designing a population-based payment system that gives all providers a chance to gain from doing what it is that we want them to do. Second sort of high-level point here is that ideally we could articulate a long-term vision for how we want the payment system to be designed and then back solve. A lot of the activity so far has been framed in a sort of more test and scale mindset in which we seek to try a bunch of things, see what moves the needle, and then with an eye to expand on what does. And that kind of assumes that short-term progress should dictate long-term policy. I think that mindset has made reform and discussions a little bit more myopic and more atheoretical than it ought to be. And it also fails to acknowledge that there are trade-offs involved. I mean, at some point, roads will diverge and we'll need to choose a path. So instead, I think we can and should think through how various approaches might play out a bit more, try to arrive at an informed direction, and then head in that direction in a more deliberate fashion, and still while evaluating and recalibrating and pivoting as needed along the way. As an aside, I would say the same about sort of broader Medicare reforms. We really just need to have more discussions about what we want the program to look like and why. Next sort of high-level point, the complexity in the models has gotten really out of hand. This has been sort of brewing for a while. The model proliferation has been a problem, just the sheer number of models. But also each model can get really complicated in its own right. And I think this happens in part because when the destination isn't super clear, a model can take a sort of circuitous route, collecting baggage along the way and needing sort of rule changes on the fly. And then there's also been a tendency to pack each model full of its own quality metrics and requirements. And all this creates an administrative burden for providers that makes participation more costly. So my general view is that at this point, we should be focusing on fewer models and making them simpler and better and more harmonized. As I've been alluding to, the design of the model is really critical. So we get out of APMs what we design them to do. what we've seen so far, the modest savings, the selective participation, is all quite predictable based on the model design. I think this has been generally underappreciated in the policy debate, with many people conflating the concept here with the execution and concluding that we should just abandon the concept rather than try to improve on the design. And there's a ton of technical stuff here to dig into. Hopefully we have time to do so. Very briefly, I've sort of listed some of the main issues here with the shared savings program in mind. Savings rates probably need to be higher, need to work on benchmarks so that the incentives to participate and save are stronger. The goal is probably not to get everyone in a downside risk contract. In fact, downside risk can be counterproductive in a voluntary model. In contrast to MA plans, ACOs are pretty limited in how they can share savings with beneficiaries. So that's one direction we can think about, is how can the savings be shared more directly with patients in more visible ways. That can help expand ACO participation as providers sort of compete to attract patients. And then obviously a lot of work to be done on risk adjustment. And then a few final points at the bottom here. Maybe I'll jump to the primary care payment reform bullet. Primary care payment reform has been a big topic of late, receiving a lot of attention, probably less attention on how it should fit in with the total cost of care population-based payment system. The key point there, I think, is we can go further with primary care payment reform in the context of an ACO contract, because there is less concern about cost shifting and the resources from an added payment should be used more efficiently. I think the recent ACO Flex model is a really good model to build on there. In terms of the portfolio that we want, I tend to favor a streamlined portfolio with a foundational population-based payment system with a fairly limited set of episode-based payments. And then finally, the multi-payer issue here is huge, and this comes up a lot. But I do want to just emphasize that it's also really important to get it right in Medicare. And if we can do that, that should help advance multi-payer alignment to the extent that better designed, more effective models are more likely to diffuse. And then finally, I do just want to note that while some of my comments may be somewhat critical in nature, I wouldn't be a self-respecting academic if they weren't. I do want to commend CMS and the Innovation Center on all their hard work and the progress so far, which I do think has been really substantial. And also note that there are probably some statutory constraints at play here that probably require some congressional action at some point, and I think what motivates the role for CMMI that much more. So thanks very much.
Thank you so much, Michael. Next, we will go to Dr. Ezekiel Emanuel, who is the Vice Provost for Global Initiatives and Professor in the Department of Medical Ethics and Health Policy at the University of Pennsylvania. Zeke, please go ahead.
Yes. From 2011 to today, I have said Vice Provost. I'm a university professor at Penn, and I co-direct Penn's Healthcare Transformation Institute. I was in the White House working at OMB and the National Economic Council on the Affordable Care Act, among other healthcare initiatives. And particularly on that was, I think I can say, instrumental on things like bundle payments, the design of the ACOs, and CMMI. I would say at that time, I had huge frustration when I called around, all right, should we put a particular payment model in? How little we knew about various payment models and how little we had actually tested various payment models. We failed, the government failed, lots of people failed. And I, on a usual day, I'm a specialist, I'm a breast oncologist, and I think one of the areas we have kind of ignored is specialty payment, since it's so much of physician payment and so much, generates so much of the system payment. I think that has to be incorporated here more systematically. Next slide. So I just want to talk about the issue of why we have gotten to 50%. I think a lot of us policymakers, academics, who don't actually run value-based payment programs don't quite understand how difficult it is, especially for smaller groups, to transition. Providers with value-based payment have to change their financial and operation management, right? Under fee-for-service, they know how to make money, they know how much money they need to make, and they know what they need to do because they get paid for doing things. Under value-based payment, they often get paid for not doing things. And that, I think, is critical, which means they have to take on risk in a way that requires a much more sophisticated analysis, which they're not experienced in. And one of the consequences is that they end up either having to affiliate with health systems or get MSO services or get consulting services, all of which are extremely expensive and take away a lot of their financial benefits by actually doing value-based payment well. And I think we don't fully appreciate how complex that is. So what are the kinds of things, both from a design standpoint, as Mike suggested, but also an implementation standpoint, that would be sort of a bare minimum and make this transition better and helpful and incentivize a lot more practices, especially the independent ones, to do it. I think we have to make data much more readily available. Right now, Medicare gives data back, and it's raw data, which is not information and not helpful to small practices. They need more timely, accurate, accessible, and actionable financial data. This is possible, easily possible, rather than giving them raw data. They need something which will tell them how they're performing individually and collectively as in a group, their patients, and that's an absolutely essential element to give them confidence they're going to make money. If they can't have that confidence, they're going to sit on the sidelines. They're not going to go into these programs, especially if they're voluntary and not mandatory. And I think that's a critical issue. I think on that path, CMS needs to facilitate the development and adoption of low-cost solutions that are in the $10,000 to $25,000 range, not hundreds of thousands of dollars or millions of dollars as Acadia and all the similar programs are, that are open source, that can be used. And here, maybe Mike and I have a slight difference. I think one of the major ways of overcoming the multi-payer problem and being sure is to Medicare use its authorities to extend the same data platforms, providing the same kind of information across all the programs where they give money, MA and exchange plans. This will mean a large portion of what physicians get and other providers get will be in the same format. So a large portion of their practice will have the same information. And they can use that wedge, as they do in many other areas, to get standardization, which I think is on the data, which I think is critical. They could also get standardization on the payment formats, which again is going to be critical. It'll also create a marketplace for solutions for financial modeling for practices, which I can't emphasize. I think this is a fundamental lesion, and unless we overcome it, we can provide a lot of different incentives, but we'll either facilitate consolidation or people will still remain on the sidelines. The final thing I'd like to say is I do agree and have with Michael, we need fewer, better design programs. Part of that design, we need a lot more interaction with frontline physicians and some real assessment of how these programs change incentives for doctors and whether they inhibit them. The ratcheting down of the baseline is a perfect case of where I think, this is really going to just dissuade people from participating because they can't make money on that. With that, I'm going to pass it on.
Thank you so much, Zeke. I can tell from the committee they're already ready to ask additional questions, and you will have the opportunity to do that. Next, we'd like to go. Oh, I'm sorry.
No problem.
For both of you, for all of you, actually. So next we have Dr. Tim Ferris, who is the founding Senior Vice President of Value-Based Performance for Mass General Brigham, inaugural Chief Transformation Officer for the National Health Service in England, and adjunct professor of medicine at Harvard Medical School. As one of our original PTAC committee members, we're thrilled to have Tim back joining us today. Please go ahead, Tim.
Thank you so much, and I want to start off by complimenting all the work the PTAC committee has done, and particularly the ASPE work that we just saw. I thought it was excellent work. I learned a lot from it, and was very pleased to see that the baton has been passed, and the quality of the work they're doing has definitely gone up since I was a member of the committee. So I'll go to the next slide, if you will, and say that I'm not going to directly address my assignment. I'm going to think about a slightly bigger picture, which, because Michael and Zeke did such a great job of going over the pieces, I want to talk about what I believe to be the biggest risk going forward to the value-based care initiatives, and that is, given the demographics of the United States, we are projected to have very significant capacity challenges in the delivery of healthcare to our populations. Most importantly, to the populations where the payers, primarily Medicare and Medicaid. And that problem is not, just to be clear, it's not getting smaller, it is getting bigger, and it's getting bigger and will continue to get bigger for the next 20 to 25 years. That presents a real challenge, right? So I want to underscore something Angelo said: to make accountable care the financially viable model of care. Just to underscore that, so how will we do that when the literal capacity that is available doesn't meet the needs of the populations? That's really critical. So who is, this is all about accountability, and I wrote here defining accountability. Who is accountable for the capacity of the health system? And I'll just project out there that right now we have a system that's set up to say, well, if we fund it, they will come, right? That's how we manage capacity in this country. That's problematic when two of the major payers pay generally below the costs of delivering services. So the costs of delivering services, the unit costs of the delivery of care, is the core issue for me in value-based care delivery. And so if we think of if health is increasingly determined by access, and access is a function of capacity, then how are we going to make sure there is adequate capacity? To me, the only solution to our capacity problems is to move from what is generally a one-to-one model of inputs to outputs in healthcare to a one-to-many model of inputs to outputs in healthcare. That means we need to undergo a very large and systemic technology moving healthcare to be much more of a technology-enhanced service. Now, what I don't see in all of this, and I want to take Michael's point, I see enormous good here. My job here is not to keep complimenting all the good. My job is to point out risks. I think that's my job. And so I want to make sure that we all think about the capacity issues created through risk-based and accountability-based systems, and remind everyone that the fundamental form of accountability in U.S. healthcare is that every delivery organization, whether it is a private practice, a nonprofit organization, or a for-profit organization, is accountable as a business, period, full stop. And if you can't have a viable business because of the payment system, then you won't have those businesses, particularly in places that are serving the underserved. And so what is the mechanism by which value-based care incents the adoption of technology that allows a transition from a one-to-one model of inputs to outputs to a one-to-many model of inputs to outputs? So that's the concern that I'm most focused on now. I will say there are some smaller, more logistic things. I do think the previous speakers talked about the burden. I think there is this substantial opportunity to use technology to lower the burden on both individual practices and health systems. I do think quality metrics should not be aggregated at the payer level. That's not the relevant unit of delivery. The relevant unit of delivery is the practice or the health system. And that's where, across all payers, we need to aggregate quality metrics. I do think there's something called payment with evidence at CMS, initiated quite a long time ago. But I don't think we should be, providers shouldn't be delivering services where they're not measuring the outcomes of those services. And again, with technology today, measuring those outcomes is not an expensive thing to do. It's just that we don't do it systematically. And then my final comment is, even though we're talking about value-based payment and incentives, underneath that, the chassis is still a fee-for-service system. I believe there are significant malalignments between what we pay for the delivery of services and the work required, the input cost to deliver those services. And I'll give one example. The input costs in the delivery of the work necessary for an initial visit to a doctor is a 10-fold multiple of the work for follow-up visits, and yet the payment is only slightly more for a new patient visit than a follow-up visit. That is payment non-alignment with work is creating that systemic problems in the fee-for-service incentive system, which roll through into the value-based care models and actually create distortions in the marketplace. So with that, thank you very much, and I look forward to the conversation.
Thank you so much, Tim. Very interesting. And last, we have Dr. Alice Chen, who is the Chief Health Officer at Centene. Welcome, Alice. Please go ahead.
Thank you so much. Good morning. Thank you for having me. Many of the points that the other panelists have made resonate. Really delighted to be part of this panel and look forward to the discussion. As you mentioned, I'm Chief Health Officer at Centene, which is a government payer squarely in what I think of as a 3M space. So Medicaid, Marketplace, Medicare. We're the single largest payer in Medicaid and Marketplace, have about 1 million members in Medicare Advantage, focus on duals. I'm going to spend a little time about my background just so you have a sense of where I'm coming from vis-a-vis our other panelists. So I think what's the bottom line is I come from this work as a PCP internist in withdrawal. I just gave up my panel of 18 years, a little less than 2 years ago. My career has been focused on the safety net, but it's really embedded in practice, going through policy and now as a payer. So I'm a little bit of an outlier because most of my career has been focused on the safety net. So primarily Medicaid instead of Medicare. One thing I just want to call out, my very first job out of college back in 1990 was as a medical secretary at Unlock Senior Health Services. And I wish I could see you so I could see how many people actually know who Unlock is. But for those of you who don't, it was the original PACE model of care. So the first organization that went to HCFA at the time to ask for capitation for duals. So I imprinted on a model of value-based care in its most fulsome manifestation in many ways. And spent a lot of time in the trenches as a medical director of a primary care clinic, pre-ACA, pre-EHR, when 60% of our patients were uninsured. So in this resource-constrained setting, I always think of necessity being the mother of invention. We discovered registries, chronic care management, set up systems for in-reach and outreach, worked with Tom Bodenheimer around primary care redesign because, frankly, it was the right thing to do for our patients. We had no data on total cost of care. We implemented eConsult to rationalize specialty care, and then really was at the very beginning of shepherding mandatory CJR model implementation. Just as an aside, as painful as it was good that it was mandatory. So that's a little commentary, as well as the first very large P4P program for our system with through the 1115 waiver with about 57 different measures, which was quite overwhelming and has really informed this soapbox I have around can we focus on a parsimonious set of measures that matter? And I'll come to that in a sec. I left, I was at UCSF and San Francisco General to go work for the state of California. And on the policy front, what was really interesting, having been, again, in the trenches trying to make value-based care happen primarily, and I think of value-based care, quality over cost is bifocal. And we were focused very much on quality because, again, I mentioned we didn't have total cost of care data, but we're resource constraints. There was a constant kind of in the background driver. At the policy level at the state, help stand up the Office of Healthcare Affordability. The levers are really broad, setting up primary care spend targets, again, trying to shepherd the state towards a parsimonious set of measures. And then when I got to cover California, that was where I felt like we could really make progress on this idea of alignment. So when I was at Covered California, we worked with Medi-Cal and CalPERS, which is the public benefit organization, public benefits manager for the state of California, to land on a parsimonious set of measures in order to create clarity for the payers that we contracted with, and hopefully through those payers down to the provider level. Because what we realized is all the purchasers, which together covered 42% of Californians, were contracting with largely the same payers. And then the payers were contracting with the same providers. But because there wasn't alignment, there was a lot of kind of diffusion of intent or voltage drop from purchaser to payer to provider. And so I took that experience with me when I came to Centene last January, and I walked in the door with the lofty goal of driving population health agnostic of value-based, agnostic of line of business. And I will say, had a rude awakening from a payer perspective. Medicare VBC is fundamentally different from Medicaid, which is, again, different from Marketplace. And a lot of it has to do with the provider landscape and capabilities, how much clarity there is in terms of what you're driving towards, for better or for worse in Medicare Advantage. Stars performance is the North Star. So there is zero doubt about what you're driving towards. And then there's also the issue of churn. Let me just move to the next slide so we can start the discussion. But while there are a lot of things that we can address in order to make value-based care and accountable care more feasible, I think a relatively low-hanging fruit would be measure alignment and focus. And so as a company, we track 170 measures across the 3 M's and UDS, which is, for those of you who don't know, is a measure set for community health centers. As the single largest Medicaid payer, we are partnering with community health centers, FQHCs, because they are such a critical part of the primary safety net, primary care landscape. Out of 170 measures, aside from CAPS, there are 4 that are common across all programs. What we've done is, in terms of our value-based care strategy, is, again, by line of business, Medicare is focused on STARS, Marketplace is focused on Marketplace QRS, and Medicaid is focused on primarily the state withhold measures and hopefully in the future MAC QRS. But internally, we've tied employee incentives to quality performance on these 4 measures that span all 4 lines of business, as well as because we are the largest Medicaid payer, pre, post, and well child visits. So trying to figure out from a payer perspective, how we create greater clarity and simplicity and easy button for providers very much depends for us as a 3M payer on clarity from CMS. So I will pause there and look forward to the discussion.
Thank you so much, Alice. A wonderful presentation. These are great introductions. So next we want to move on to some questions. And in the interest of ensuring balance across different perspectives and questions, we encourage each of you to keep your response to a few moments. And committee members, I want to encourage you to tip your table tents up when you're ready to ask questions. I know I can see you chomping at the bit to jump in. So please feel free to do that. But I'll kick us off with one overriding question. What should be the vision for developing total cost of care models that can help to ensure that every Medicare beneficiary with Parts A and B is in a care relationship with accountability for quality and total cost of care? And let's start with Michael and then go to Tim.
Great, thank you. I did want to just loop back and just say that I think Zeke and I are actually in violent agreement about multi-payer alignment and where the focus should be in terms of where the federal dollars are. I think it's just important that we acknowledge that even if we didn't have the multi-payer problem, that the models currently are probably not in a state where we get what we want from them. And so we need to sort of work on those things. But targeting, trying to align across Medicaid, the Marketplace, and Medicare seems to be where the focus should be. In terms of vision, I think ultimately what we want here is more efficient and more flexible care delivery. I think sometimes in conversations about payment reform, the framing can get a little contorted and imbued with a little bit of magical thinking. And while we certainly should hope for some direct benefits for patients from efficiency and flexibility, not being subjected to harmful procedures, being able to get remote case management instead of having to come in the office or getting home care instead of facility care, I think there's a broader system goal here in which people benefit more indirectly that we shouldn't lose sight of, which is lowering the cost of healthcare. And just to pick up on what Tim's point, if we can do that, then with all this great stuff coming down the pipeline, we just have more money to spend on valuable things, whether that's healthcare things like GLP-1s or non-healthcare things like food and housing. If we can just figure out a way to try to wring some of the waste out of the system through the payment system through payment reform, everyone wins. And so I think that just, deserves reiteration in terms of sort of what the ultimate vision and goal is. And then, in terms of accomplishing that, I think we've already hit the high points in terms of the pieces, maybe digging into them a little bit more on the model design front, as Zeke mentioned. Getting the benchmarks right is probably the foremost thing to do, and there are a couple dimensions that we really need to work on more there. One is the sort of ratchet effect that Zeke alluded to, where if an ACO lowers spending, its benchmark comes down. The shared savings program this year introduced a prior savings adjustment that helps mitigate at least some of that during the sort of rebasing between contracts. But also, I think a lesser appreciated part of this is ensuring that the benchmarks accommodate more participation by basically allowing every provider a chance to get under their benchmark. And that can't happen if we grow benchmarks at realized rates of spending growth, because then the benchmarks just are continually dragged down as providers save, and then the model can never be appealing to more than roughly half of providers. And so there are various ways to approach this, but I do think these are the types of things that we need to be talking about, and they get pretty technical. One way is to have a sort of preset administrative benchmark trend that's just fixed over time, to help that sort of wedge between benchmarks and claims expenditures emerge as ACOs save. The Shared Savings Program introduced the accountable care perspective trend this year to sort of introduce that. Or we can have add-on payments. So that might look like a permanent APM bonus or an enhanced primary care capitation payment that's sort of permanently in place for participants in ACO programs, or a combination of the approaches. But I think we kind of need to think about, how do we think benchmarks should be set 10 or 15 years down the road, that might involve, look sort of like a risk-adjusted rate book, but not one that's set at like average realized spending. And then ask the question, how do we get there? And then there, the rest of the pieces like savings rates and, risk adjustment deserves a lot of attention right now. But I think this conversation gets pretty technical pretty fast. This may not be the forum to do that, but these are the conversations that we do need to be having.
Zeke, did you want to comment on that or ask a question?
You wanted Tim to, I just want to get in before you move.
Oh, definitely, we'll make sure.
I can see Tim is also chomping at the bit, so
This
I'm
is
not going to
great.
stand
Exactly
between
what we
him and
wanted.
the race.
Yeah.
Go ahead.
Okay, well, sorry, I'm hearing it. No, okay. I just want to, if people have spare time, looking back at the recording of what Michael just said would be well worth their time, because it was really, really important. And I couldn't agree more with what Michael just said. I will put out there, Michael, just to have the conversation, that the benchmark should be general inflation. Healthcare rises at twice inflation. If it rose at general inflation, it would not be confiscatory, and none of the problems created by healthcare for the rest of society would exist if it simply rose at inflation, which it has not done in the past 50 years. But with that aside, I'm going to, because I think Michael answered the question very well, I wanted to go in a little deeper about the implications inside a delivery organization of being in value-based contracts. And just say that I think it is, and actually Don Berwick wrote a paper for the New England Journal about this, I think in 99 or 2000, which is clinicians shouldn't be directly exposed to incentives on total costs of care for populations. That is a very problematic place for a clinician to be. And so internal to an organization, the bigger the organization, the better, because the more stable the population, the more predictable the expenses. And it looks like I've got Zeke might have an issue with that. But just saying that I believe it is for the executives within a provider organization to have incentives in their pay around total cost of care for population. But then they need to transform those incentives into quality and outcomes and medical management decisions for the providers within that organization. I wrote a paper about this, I don't know, a dozen years ago, that it sort of explained the layers of transforming the total cost of care incentives at the highest level down to physician level incentives. So I just wanted to emphasize that important piece of this puzzle.
Thank you so much, Tim. And Zeke, I want you to go ahead and please, part of bringing all of you together with your brilliant perspectives is the dialogue and interaction. So please, everyone, feel free to jump in. Zeke, please go ahead.
So again, I just want to iterate. I think what I disagree with, Tim, is that bigger is always better. There's a capacity, there's a maximum size. I don't know what it is. I suspect it's around 40 or 50,000 people that the group needs to be. That's a sort of minimum. I don't know what the maximum is. Anyway, I do think there are several things that need to be addressed simultaneously. And I think disengaging them and only focusing on payment is going to be a mistake. Payment is critical, but as Michael said, risk adjustment's critical here too. So if you're going to have here I'll put on my card, primary care doctors need to be capitated, and they need to be capitated consistently across the groups. And you need to take into account the problems mentioned by both Michael and Tim, which is the problems of, our fee-for-service system is just screwed up. We have to take the top 250, 300, 400, some number of the billing codes, and we need to reevaluate them because they influence. And it's really only 200 or 300. It's not, 10,000 that we use, because those are account for 90%. That capitation, I think, is critical. It has to have bonuses for quality. You have to measure quality in a standardized format. I think both Tim and Alice talked about this. Way too many quality metrics, too many payer. CMS needs to use its power that it's paying all these people to make everything consistent. And as Tim said, 100%, it's got to be at the provider level, not at the payer level. So CMS has power, and they need to use that power to standardize these things. Then there comes in, so you've got a capitation, you've got standardized quality metrics across a wide swath of payers. You need risk adjustment. Now here, I can say definitively, because we are doing machine learning-based risk adjustment, and CMS is fully aware of this. We can improve the HCC score 3 to 4-fold with the simplest machine learning program using the simplest data that Medicare uses. HCC is broken, and they have to get off it. We cannot continue with it. It's not state of the art, and it creates all sorts of perverse incentives. But risk adjustment isn't going to work until you cream off the top 5% for a reinsurance program, because they drive 45 to 50% of spending, and it makes a huge difference to doctors if you cream that off. I mean, not just doctors, but health systems. And the last thing, I think you're going to establish this capitated risk-adjusted capitated payment with a reinsurance program for the top 5%. You have to combine that with bundles and reference pricing, I think, for as many specialties as you can. Certainly procedure-based specialties. We've got enough data on hips and knees. We've got, we're going through to get bundles on spines and cataract surgery. Lots of the very common surgeries need to be bundled. Are you going to get the bundles for, you probably can get the bundles for stent placement and things like that. I don't know of another way to get the specialties in. You're not going to capitate them, but you've got to get them in on the bundles to lower and where that bundle payment has specialty involved. And I think that combination is where we're going, and to standardize it across as many payers as possible is the only way forward at the moment. Can
I just jump in with a couple of additional comments, given what people have said, which is I couldn't agree more that clinicians shouldn't be exposed to direct total cost of care pressures. And that does assume, I think, as Zeke said, like a certain size and sophistication that just isn't there for a lot of providers. And then you have this whole layer of intermediaries who come in, and I think the jury's out in terms of the role of these groups and the total value add, both to the practice and the system. But I think we're seeing that happen not just in the Medicare space, but increasingly in the safety net space. The other thing I just wanted to pull on was I love the idea of quality being aggregated at the practice level. Frankly, I say to my payer colleagues all the time, care happens in the provider space, in the community. We are not providers. And I think in my experience as a purchaser, a payer, and provider, when you start mixing up your levers with someone else's, you just start swirling. And so just trying to remember, like, what are the levers at the purchaser level in terms of contracting with health plans? What are the levers at the payer level in contracting and supporting providers? And what are your levers at the provider level? I think it would actually do a lot to take waste out of our system in terms of the amount of energy that goes into each payer trying to optimize its data collection in terms of, HEDIS measures, supplemental data, chart chase, things like that. It also does have the potential for unintended consequences. And I do think, I forget who mentioned risk adjustment, but from a payer perspective, I'll just say, once you have a score, as labeled on the forehead of each provider, the next thing obviously is to selectively contract with those who have the highest quality scores. The issue being, obviously there's the tension of network adequacy and essential providers and things like that. But I worry about the safety net providers in particular, who for a whole variety of reasons aren't able to perform at the same level.
So helpful. Go ahead, Michael.
So I just wanted to do some combination of piling on and maybe trying to cinch one of the points that came up here, which is, and it sort of, I think we hear a lot of conversation about, I need to figure out how to lower my hand here. It's often said that people are frustrated with how the incentives aren't making their way down to the physician level. And I think Zeke and Tim and Alice all just said that maybe that's actually not what we want to happen. We certainly don't want physicians exposed to fee-for-service incentives purely, and something more like salary is probably more desirable. But we don't want the incentives in an organizational contract to just be devolved down to physician level, because that defeats the purpose of having an organization, which is to pool risk and to get organizations to do things that individuals cannot. And I think that's just a really important point that I just wanted to cinch there.
Excellent. I'm going to go on to our next broad question. You've already started to tap into this. So why have some providers not been signing up to participate in total cost of care models? And what can be done to address barriers to participation? We thought we'd start with Zeke and then go to Alice.
So, I mean, look, I've already weighed in almost all of my things. Look, you have to begin with giving them enough data for finance and a reliable financial model that they don't have to pay through the nose for. I think Michael just talked about, or Tim, someone talked about all the, no, Alice was the one. I'm getting confused here, about the financial intermediaries. Those intermediaries are really expensive, and they take a lot of the savings, and they take the incentive away from participating. And I think if Medicare gave away or made very cheap a lot of the data that is needed and the financial model that could be built on it, so people could pay in the $10,000 or $20,000 range rather than the $500,000 range, that is a very important thing. People need to have a model, a financial model, that they can then understand if they change their clinical practice, this is the implications on the financial model. They don't have that, they ain't going to do this. It's just that simple. And so I think, and we don't have that financial model out there. And when, we've talked to CMS about it, their first reaction is we give out raw data. Raw data, it's not something doctors can use. They need it processed for them, and they shouldn't have to pay a lot of money for that processing. And then above the processing, they need models. If I change my clinical practice this way, what are the financial implications? That's not obvious in a value-based payment world or a capitated world. And so those are the two things I would say to begin with. And then I think I want to emphasize things that others have said, which is we've got to have a benchmark established where primary care doctors especially can make money. I mean, specialists are already making a lot of money, but the primary care doctors need to have a benchmark where they can make they can see how they can make money, and they can make a substantial amount by providing more as bonuses by providing high quality care. Because that if they can, increase by 50% their income, that's a very big incentive for them. And screwing around with 10%, it's screwing around. It's just not going to do it from an incentive standpoint, given all the work they're going to have to put in to transforming their processes of care. Yeah.
I would second, third, and fourth, Zeke, on data. Like, I think data is foundational. I do think, as a plan, we are working very hard on trying to figure out how do we get the right data at the right time to the right people. I think, it's interesting. I think in the U.S. healthcare ecosystem, payer and provider tensions are large and sometimes unrelenting. And I heard a great quote recently, which is you squeeze a vendor and you hug a partner. And I do think that in terms of payer-provider relations, we need more hugging and less squeezing. I know that's Pollyannish and, you know, easier said than done, but I do think that particularly for us in the Medicaid space, there just aren't that many margins to go around. And so it is essentially by necessity, it's like you have to partner. So I do think data on timely, actionable, relevant data that people then actually have to have capabilities on. I think from the delivery system side, I would say one of the big barriers is, I mean, primary care is exhausted. I mean, you have primary care providers who are just burnt out, supply exceeds demand, and it is really hard in that setting when you are just trying to get the people you've been caring for 10 or 20 years in the door to think about people who aren't coming in, let alone people who are assigned to you, but, you know, you've never even laid eyes on. So I think the capabilities in terms of just the plain old, you know, primary care redesign. I mean, again, you're giving me flashbacks to, you know, 20 years ago around third next available, same day access, you know, team-based care, leveraging technology. I do think leveraging technology is a huge piece of it. That was where eConsult became kind of our solution to a huge supply-demand mismatch for specialty care. With that said, I just want to put a note of caution in terms of technology. Is I do worry, particularly with telehealth, that we will move towards a future where poor people get virtual care and rich people get the care they need at the time they need it in the form they need it or they want it, right? So I think technology is an enabler. We need to lean very, very hard into it, but there is an equity aspect of it that I don't want to lose track of.
Very important points. Tim, Michael, do you want to comment on that question?
I agree with everything that's been said, and may add just a couple other potential sources of sort of friction or slowness in the participation curve. One, just picking up on what Alice just said, because of the way that we've traditionally set benchmarks according to sort of an organization's own history, for providers that serve historically disadvantaged populations and therefore for whom we may underspend, it may be really unattractive to enter a payment model in which that sort of historically low spending is entrenched. And so that goes, in my view, to sort of a new frontier in risk adjustment, which I don't think should think about as improving the statistical or predictive accuracy alone, but also thinking about where we want spending to be, where it ought to be for some populations and not where it's been. And so that's one thing that I think could help bring in some providers who otherwise just would, you know, the models would be unappealing. And then similarly with risk adjustment, you know, if you think about how the ACO programs have handled coding incentives, it's to cap risk score growth. And obviously for the providers who have not gotten good at the coding game yet, then they just might want to sit on the sidelines a little longer until they, you know, find the resources to invest in that capacity, as opposed to a risk adjustment system that would level the playing field for them, so to speak, from the get-go.
Thank you. Tim, please go ahead. You are muted.
Thank you. Sorry about that. People may not be aware of the power of the predictive capability of LLMs, but I'm just going to cite one important reference. So a group of researchers in Denmark took the population of Denmark, 15 million people, and compared actuarial approaches to statistical approaches to LLM approaches, and actually just compared them. So actuaries got it right 8% of the time, statisticians got it right 23% of the time, and the LLM got it right 43% of the time. That is a massive performance difference, and there is really no excuse for not using LLMs for risk assessment and risk adjustment at this point, given the really dramatic differences in performance. So, and then could I just say that it is such a pleasure for me to be on this call with Alice Chen, because when she published her paper on eConsults, I read that paper and I said, this is the future of healthcare. And I immediately implemented it at Mass General Hospital. And I've never done that where I read a paper and I said, this is the future, and then just did it. So Alice, you're one of my heroes. So thank you.
And you were totally ahead of the curve, because I will say that initially the only people who were interested in eConsult were safety net settings.
Yeah.
I think you were the first non-safety net group that I know of.
I'll just add to that, Alice. I followed Unlock, changed everything. Michael, please go ahead.
I just wanted to follow up on something both Tim and Zeke have touched on in terms of risk adjustment, and that is that going forward, it's just going to be criminal not to use these new predictive techniques that we have. Absolutely, and a regular linear regression OLS is just going to be a thing of the past in many cases. I'll become a relic since that's what I was trained to do. But I do want to note a couple things. One, it's not necessarily better to be more predictive if the inputs are the same and they're manipulable. That just sort of ratchets up the incentives to code. And also, the HCC model has this problem that more profligate providers get paid more, because if you do more stuff, there are more claims and more diagnoses. And so that sort of destroys the payment incentives in a population-based payment model. So we have to be careful about using things like R-squared or predictiveness as sort of like the North Star of risk adjustment. And then just sort of thinking about equity considerations, again, what's right and what's better may not be more predictive. And so we need to think about like getting new inputs that aren't manipulable, and also thinking about bringing in other information about what's right from a social values perspective in setting payment.
Key points. Walter, I'm going to go to you, and PTAC members, I want to encourage you. I'm opening it up for you to start asking questions. Walter, please go ahead.
This has been a really phenomenal session, and I just really appreciate all of our subject matter experts coming and sharing their expertise with us. I actually wanted to go back to the very beginning because I think Michael started this whole panel discussion with a very thought-provoking question, which is participation is only one measure of success. So I think where I'm coming from is here at PTAC, we've taken this goal that CMS has set of 100% accountable care by 2030 to heart. And in many ways, that's been a North Star guiding many of our discussions and public meetings. And so I'm just kind of curious, both from Michael and other panelists, what are the other goals of success, if not participation? And perhaps I'll weave into this question a statistic that Zeke brought up, which was that top 5% most expensive Medicare beneficiaries account for over 40% of the costs. On the flip side of that, I think MedPAC has published data, as well as ASPE, that the least costly 50% of Medicare beneficiaries account for about 3% of costs, right? So perhaps a goal of success might be more cost focused rather than just general participation. Love to hear everyone's thoughts.
So I guess I would say that certainly you can't have a successful voluntary payment system if no one's participating, right? So this is like really important goal and metric, but I do think it's worthwhile taking a step back and wondering whether the model is designed in a way to really accommodate high participation and other sort of more ultimate social goals, like spending less on healthcare where it's wasteful and more on other things, or more on high value healthcare. So I guess I would reframe this as sort of thinking about participation as a marker of success, a correlate, but we do have to think about how we're designing the payment system in a voluntary population-based model in such a way that it gives providers an opportunity. And it's not clear to me that the models have given providers a huge opportunity to date.
Tim, please go ahead, and then Zeke. Oh, you're muted, Tim.
I keep doing that. Sorry. So I'll just put it out there and restate something that I said before. Well, I agree with everything Michael just said. I'll be maybe a little bolder and just say the outcome that we're looking for is healthcare costs to rise at inflation, period, general inflation. And that should be our goal with the, and that's the denominator. The numerator, of course, is better health. But since we're focusing on total cost of care here, I think total cost of care should rise at general inflation. That would be a massive victory for the country and achieve all of the future predictions about the impact of healthcare spending on the U.S. budget would go away if it were simply true that healthcare rose at general inflation.
Zeke, go ahead.
Yeah. So I would say that participation is one metric. The other two or three, I would agree with Michael. You need financially successful providers. The vast majority, 85%, 90% have to be financially successful. And the reason is we can't repeat the mid-1990s when managed care came in, lowered payments, and a bunch of docs went belly up. We don't have enough primary care doctors, as Tim started with. The system doesn't have the capacity to have a lot of our providers go belly up. So financial success has to be there, and we have to design the system with that in mind because that goes along with participation. The other thing is, I think many of us have said, you need to deliver high quality on a core set of metrics. And, we can argue all day about the core set of metrics, but you got to look at the common things and the common things that cause a lot of disease down the line. So hypertension, number one thing we did over the last 60 years that brought mortality down, control hypertension. Today, we're doing an absolute abysmal job as the standards have come down to 120 over 80. That has to be the metric. We're at 24%, I believe, the CDC's latest data on hitting that metric. And we have to hold all the groups accountable to that metric. Same thing with diabetes. 5 critical things. Those both have very long-term downsides. And then there are very specific things for very specific populations. We can't have a proliferation of 64 outcome measures, but I think, 5 or 6 that are really big and impactful and easily measured, is the hemoglobin A1C over 7 or under 7? Is the blood pressure controlled? Is the cholesterol controlled? These aren't complicated. They really aren't. And I think having that high quality on a few core chronic illnesses that are very prevalent. And I love Tim's pounding away at, if we just keep healthcare cost increases to inflation, the world will change. Now, we have done that very well, or at least we kept it to the growth of the GDP, which is a different metric. We've done that very well for 15 years, but all the predictions are for, everything's coming unglued in the next decade. And I think keeping that as a metric, we're not going to increase the amount we pay more than inflation, and that's the end of the day. And we're going to have to just live with it.
Do you mind if I jump in before we change?
Go ahead, Alice.
For another question, which is, I think this is a really critical question because healthcare is full of really good test takers. And if you say the goal is participation, we'll figure out how to participate. I mean, I remember 10 or 15 years ago talking to a friend at Partners, and they were saying 50% of our patients are in some value-based arrangement. And it's like, but what percent of your revenue is at risk? It was like a penny a patient. I mean, I'm exaggerating, but it was not a lot of revenue at risk. And then getting to covered California, covered California in our contracts, we said our payers have to have 30, 20, 30, then 40% of their contract with PCPs in HCP land 3 or 4. But like the devil's in the details, right? And so I think people hit these marks, and even here at Centene, just having the internal conversation where we have 45% of our Medicaid providers, 46% of our Medicare providers. But again, if you're measuring it by actually outcome, like is the total cost of care stabilizing? Are we doing better in terms of clinical outcomes? The answer is no. And so I think that's where you see a lot of states in particular leaning into, you know, the Massachusetts Health Policy Commission. California has the Office of Healthcare Affordability. It's like, we need multiple tax because frankly, and I forget who said this in the beginning, but value-based care needs to really mature. I think part of it is that partnership model. Like, how do we really align incentives between payers and purchasers, payers and providers to really drive the outcomes we want in a singular way? And there are going to be other avenues. So setting cost targets, setting, you know, mandatory measure sets. A number of the state transformation collaboratives in HCP land are again landing on a parsimonious set of measures that they're trying to put through their departments of insurance or their Medicaid, like really trying to do some convergence, because ultimately I think we need to hold ourselves accountable for the outcomes, not just participation.
Thank you so much. We're going to go to Chinny and then Larry, be prepped, and then Jay. Go ahead, Chinny.
Thank you for the panel. This has been an incredible dialogue. A quick question that I wanted to actually first ask of Tim, and then would love the rest of the panel to weigh in. I want to double click on something you had said, Tim, that clinicians should not be exposed to incentives and total cost of care. So having led a large multi-specialty group through transformation into value-based care, where 95% of our revenue came from fee-for-service and only 5% came from value-based care incentives or value-based care revenue, you know, we were allowed to do 30% of our primary care and hospitalist income in a bonus structure and 15% on specialty, including our spine surgeons, retinal surgeons. So that was really powerful for us in transforming the organization into thinking about total cost of care, because we did have total cost of care platforms we were trying to implement. So I guess the question to you is, you know, that experience has shaped that, at least for me, the fact that, you know, providers do need, or physicians do need to have some money on the line here. The other thing that I'm concerned about is that we do capitate primary care, but we don't allow the incentives for actions to flow down to the providers, that the people in the middle will ultimately take the benefit of the money that's produced by bending the cost curve. So I'd love to hear your opinions on that.
Great, and I don't have my mute on this time. It's a great question, and the answer, unfortunately, for me, I'm sure someone smarter than me can explain it in a simpler way, but I will I'm happy to get you the paper. It's Brian Powers et al. On aligning incentives. And it was basically the construction of what we call the internal performance framework. And basically what we did, and this is directly related to what Alice said about what was going on in Massachusetts and the Massachusetts Health Policy Commission. Once we had all commercial payers, all Medicare business, and all Medicaid business, all were risk contracts. Basically, everything we did had to be in the context of a risk contract, but nothing lined up in terms of the incentives. So we created an internal performance framework that created a set of metrics different for primary care, specialty care, procedure-based care, across the health system. And so, yes, our clinicians did have incentives, but how we performed in those contracts, like literally the contractual basis, and how we built the incentives were different. Now, they were aligned, and there was a lot of angst from my CFO about, Tim, the farther you remove yourself from the contractual target, the more anxious I become that how we perform in the contracts will be different than how we perform. I said, you know what, it's going to work out in the wash as long as we keep the North Star of better outcomes and more efficient delivery of care. And honestly, it doesn't matter what the payers are incenting us on if we construct this. It turns out it worked incredibly well. After the first couple of years of a lot of anxiety, we've actually, my former group, has performed for over a decade, actually quite well in these contracts across all types of payers. And so it is a complex process of translating the higher level metrics and some of the detailed metrics into what is it the provider thinks is best for patient care. And can I just add as a codicil to that actually the internal process of saying, what do we think we should be measured on, was a very healthy process, because it actually got people in the room saying, okay, the payers think it's this. We don't think, it's not that they're completely off target, but that's actually not the right way to measure, for example, hypertension in our populations. We have much better data on this that we can extract from our electronic medical records. Why don't we make a better metric on what we have a shared agreement on as an outcome? So I'm sorry, that was a bit of a long answer, but the real answer is actually quite detailed and is in that paper.
At the risk of just like piling on and echoing, I just have to say, I do think the role of clinical leadership is both translating and being nuanced about what you pass through and not, because you want to tap into kind of the psychological raison d'etre of providers. And like I say to my payer colleagues all the time, we don't want to contract with a provider who the first thing they do is their insurance card and what line of business. I mean, you want providers who are taking care of patients. But then how do you then align the incentives for us coming from purchasers, government, through us, to our provider partners in a way that that really, again, makes sense on the provider side, but also allows us to succeed. I mean, that's where a lot of the conversation is for us.
Michael, go ahead.
I do think we need to be careful here. There are some real downsides in passing through risks to the individual physician level. It gets very noisy, risk adjustment falls apart, it can be demoralizing. You end up introducing financial conflicts of interest at the sharp point of care where perhaps they ought not to reside, and we'd rather have physicians' intrinsic motivation push back against organizational incentives. So things can go badly when this is done. I think also it's important to think about what it is that's eliciting the behavioral change. So as a physician, I've always just been exposed to very symbolic financial incentives on the quality or cost front. But they nevertheless, so they're fairly meaningless from a financial perspective, but they can nevertheless elicit behavioral change because physicians are super competitive with themselves and others, and they pay attention to data and may open their eyes to various things. There have been papers in the economics literature that shows that just presenting data to providers actually can change their behavior. That was sort of the story behind surgeon report cards, for example, in large part. And so I think it goes to something that Alice just mentioned, which is, we should be thinking about this debate about how much to pass along to individual physicians, but we also really ought to be thinking about the science of management and updating that and not having it be too Tayloristic and using behavioral insights and trying to tap into people's professionalism.
Zeke, did you want to add on?
No.
Okay, Larry, please go ahead.
Well, I have to pile on to what Walter said. This has been just a fantastic session. What I've loved is the interaction between the four of you. And that's something we don't always get, but it's been a great discussion. I was feverishly taking down notes to capture statements that were meaningful, and I have some from all of you, but there's a theme that permeates this. When I look at capacity challenges, the statement, if we fund it, they will come, that we have to have systems that are accountable as a business. We need to focus more on where we've been ignoring specialist payments, revenue at risk. what's come through to me from all of this is that we're not just providers, we're businesses. And these businesses have to succeed. The physician practice has to succeed, and so does the health system have to succeed. And our payment systems have to find a way to align business success drivers with population health needs. And right now, that isn't occurring. And I guess my major question is, should we, instead of focusing on providers, have a focus on the provider businesses to create the payment solutions that will allow everybody to thrive?
Can you clarify that?
Well, for instance, I'm a gastroenterologist, so I've lived in the GI world my entire 40-year career. And in my last 10 years, I've been involved in value-based care for patients with significant chronic GI diseases. We can't get the attention of the providers because they'd rather be in the GI lab doing colonoscopies on healthy patients, because that's what's driving their revenue. And when we come in with a value-based care program that may give them 1% to 2%, the answer would be, I'll just do another colonoscopy.
Okay, let me at least address that in particular, because we've been trying to work with some GI docs for, and the same thing is the case. First, as I said, you're going to have to revalue those fee-for-service payments. There's just no two ways about it. We overpay for lots of procedures. We know we underpay for E&M. I think Mike gave an absolutely fantastic example about, the initial visit being grossly underpaid. Whereas for some other things, the initial visit is excessively paid. I believe ophthalmology is one of those cases. So I think there's just no way of moving forward without revaluing that element. And, it's one of the reasons I suggest, bundle payments for upper and lower GI scoping is going to be critical to doing that. So that's absolutely essential. And I think this is where I think voluntariness, I've been against voluntariness from day one. I lost out to many people inside because I don't think if we make it too voluntary, then the people who are going to win enter. And if they can leave, they'll leave if they're not succeeding. And so I think mandatory is very important going forward. So I think that is going to be the case. And the last thing I would say is, one of the reasons I keep emphasizing the data and the financial modeling is you have to show doctors how they can succeed. And if you don't have that modeling, you can't. I also agree with you. I think I've said it very explicitly. Unless you make the bonuses really big, this is just not, with all due respect for professionalism, in the end, if you can't make 30, 40, 50% more by doing a very good job, you're not going to get people's attention. I don't think 1 or 2 or 5% does it. And so I think those are the two things I would focus on: revaluing and keep the AMA out of it, and making sure the bonuses for really high quality are really big.
Zeke, if I could just follow up one quick question on what you said earlier. You've said that primary care should be capitated and procedural specialists should have episodes and bundles.
Yeah.
What about the cognitive specialist?
Yeah, look, I'm an oncologist, and I helped design the original OCM model. I think it's way more difficult to do that right. I think there are ways of fixing that system too, at least at my specialty. You've got adjuvant care, which is well-defined, good standards for a lot of good guidelines that you can base things off of. And then I think you need some triggers for examining or limiting, third-line chemotherapy for metastatic disease is, just not on, or, triggering a review at ECOG when the ECOG status goes down. Then it really gets into the weeds. I think it's just much, much harder there. And, I think a generalized solution is probably not likely. You're going to need some specialty specific stuff.
Michael, please go ahead.
Just pulling on that thread a little bit more. So if we're thinking about large bonuses for quality, given that we can only put so much money on the table, and I think Zeke emphasized this before, we're going to have to be pretty selective with the measures, right? And then so that's sort of one thing we need to think about. I'm trying to think through the best way to say this, but going back to sort of thinking about who should bear the risk and thinking about quality in particular. So that's a good example, perhaps. The bonuses could be quite significant. We probably still want them at a practice or organizational level, given that that aggregate sort of actor is going to be able to do more about the systems problems at play, right? And so I think in thinking about sort of management and professionalism, the real trick here is for an organization to be able to respond to a large bonus for a measure that we really care about, can measure well, and do all the risk adjustment for, et cetera, in a way that changes clinician behavior without necessarily relying on passing through the incentive in full because of all the problems that comes with that. And I think that's where certainly a lot of action, a lot of research is being done in terms of nudges and sort of behavioral, drawing from behavioral science. But I do think that's something that still does not get talked about as much, and we need to be working on more.
I'm going to go to Jay next for the sake of time. Please go, Jay.
So I'm going to pile on. This has just been an incredible discussion. The only downside, it makes me feel old because we were having these same conversations at U.S. Healthcare 30 years ago. And it's a flash forward, capitated primary care physicians, bundling for specialists. But Zeke, you triggered on something which is my real question is, we always talk about getting rid of waste, how do we pay differently? How do we address demand? What can we build in the system to reduce demand, especially in the context of social determinants of health with fixed budgets? Are we going to pay for housing costs? Are we going to pay for food as medicine, which is now being more prevalent in Medicare and Medicaid programs? Or we're going to pay primary care physicians more and specialists less and hospitals less? How do we work that in to the system?
Well, look, that's a more general, complicated question in the following sense. Right, we have a food stamp program, a WIC program, and a bunch of other food programs. We have a dysfunctional housing system, and yet we know all of those things have a big impact on health spend, transportation added to it. I think, and healthcare isn't great at its own administration, and to ask it to administer food and to ask it to administer housing is probably a bad idea if we had functioning social systems. So I'm not a big advocate of let's layer on everything onto the healthcare system. But I do think two things. I'll go back to what Tim said, which is, the part of the strain on things like food stamps and housing are a direct result of the increases in healthcare costs. And if we could moderate those increases while the GDP grows, I think we create, some extra money that can be spent for various things that are super important. Until we can get to that kind of stage, I think that my personal view is there are two things we should substantially encourage the healthcare system to take over. I do think nutritional food is exceedingly important, and healthcare either directly to work with provider to make sure people get enough food and to work with the schools for kids. The second thing I would say is, this is part of long-term prevention strategy, and we don't invest enough. And if I were God, the thing I would force us to invest more in is early childhood interventions, because they're critical for, developing kids. They're critical for their brains. They're critical for their nutrition and avoiding obesity and the subsequent hypertension, which we're seeing a whole lot of in children, diabetes as well. So those are the two things I would make us pay for. Now, the latter, early childhood interventions, do fall directly under healthcare. And I do think those are things we ought to mandate. Sorry, Alice, I'm going to say this. Every Medicaid program be responsible for, I don't know whether it's nurse-family partnerships. I'm not going to specify the exact kind of program, but early childhood interventions that take kids all the way through 2 years old. But I do, we have a dysfunctional social system on lots of levels, which is why all this stuff is getting layered on healthcare. Not that we're going to manage it so much better, but, providing people food is critical to them recovering.
Let's go to Tim, then Michael, and then Alice. We've got about 3 minutes just to give you context for your comments. I know we could talk a lot longer about this.
Yeah, I'll go really quickly. So I would just want to underscore everything Zeke said. I completely agree that the movement of moving more and more social care under healthcare, it just it is probably not the right way to do it, even though that the incentives are actually moving us to do that. I'm going to say something I think helpfully controversial, and just say that it is not great incentives for the demand on healthcare if you or your employer pays an annual fee, no matter what happens. I just want to emphasize that. We have designed a commercial insurance where you, as the person who is consuming healthcare and paying into that, gets no benefit from not utilizing those services. None. Think about that for a second. So what Zeke said about prevention, so prevention is a long-term thing. Why, if you spend an annual amount out of your paycheck and your employer sends an annual amount, like 50 to 60% of all healthcare costs are 100% predictable. It's like there is no insurance for a predictable cost. It is a predictable cost. So getting the consumers in the current design of commercial insurance is a strong incentive against the self-management of the use of healthcare services, and also prevention, because Medicare picks up the tab after age 65. So that is a fundamental flaw in our system that affects the demand side of care actually quite strongly.
Thank you. And Michael?
So 100% agree. Having dollars for social services flow through the healthcare system is just not efficient. And ideally, we would be doing that in some other way. I think an argument is that, well, the dollars are in the healthcare system, and so let's use them as efficiently as possible. And that is reality, and so we should do that. But even thinking in an ideal world, clearly we want the healthcare system, to the extent that they interface with patients and their social problems, to be trying to help at the margin, at least insofar as it helps their healthcare, right? So you can think about arranging transportation so that patients can get to important visits, or waiving parking, or giving tablets so that they can be have virtual care. So, certainly there's some very reasonable things to be doing. And one might ask, what is the role of payment reform in that? And I think that goes back to risk adjustment. If we have more generous payments for certain populations that creates sort of like a surplus without any behavioral change, as long as providers are competing for patients, then that should be passed through in the form of those things. And so that's sort of like the major reason for trying to shift payment in a from between populations in ways that we think align with our social objectives.
Thank you. And Alice, I'm going to ask you to, as part of your comments, if possible, add in what are you learning in California related to the waiver, and what did you learn in the uninsured populations you paid for?
Oh, that is not fair, because I actually have a couple other comments before that, but just very briefly, like agree, like probably 95% with my colleagues here. I would say demand reduction is absolutely a long-term play. Zeke, I have said exactly the same thing as you. Like, if you're going to invest in one place, it's early childhood development, but it's not just like continuous eligibility for kids, but it's also Head Start and things that actually don't fall in the healthcare system. And as an aside, I think the beauty of Medicaid is MCOs are fierce competitors as we're going for the RFP, but many states after you get it are like, you need to play together, because this is actually a population health move, which actually circumvents a little bit of one of the problems with using the healthcare system for long-term demand reduction and prevention is right now 54% of Medicare goes through managed care, right? Medicare Advantage. 70+% of Medicaid, 100% of Marketplace, ESI. Churn is a huge issue. I've seen proposals saying like, oh, members have to stick with the MCO. I mean, my colleagues will kill me, but I do not think that's the answer. That is not patient or member centric, but I do think we need ways to figure out how to create multi-payer alignment in a way that really circumvents some of these constraints. Quickly on health-related social needs, and this does tag back to California and CalAIM, which is, I think, if there are two things that we know from looking at international comparisons, it's like investment in primary care. Right? Other states are 67% primary care, 30% specialists. We're inverted. Similarly, health-related social needs, if there's one thing take home, it's Betsy Bradley. If you haven't read Betsy Bradley's book, go read it, right? Because what she found is we were looking for our keys under the lamppost. On every graph, we are the highest spending country per capita by 50%. But when you widen the spend to health and social services, we are middle of the pack. We just spend it differently. Other industrialized countries, for every dollar in healthcare is $2 on social services. For us, every dollar in healthcare is 55 or 60 cents on health-related social needs, social services. And so what I would say in terms of the healthcare system is, I have also been saying, like, you know, everyone basically says there's 30% waste in the healthcare system. Although when you ask them where it is, they're like this, right? No one's saying this, like healthcare waste is over there, but it's 30%. You don't want to put all this other spend through it unless it's really surgical. So I do think the evidence-based things are food as medicine for certain conditions, like post-discharge for CHF, for HIV. It's transportation for prenatal visits. It's supportive housing for people with SMI and SUD. So I think, again, don't just throw everything in there, because we know that that will just generate waste. But how can we be evidence-based about it and targeted in a way where, given our short-term thinking constraints in healthcare in the U.S. political system at large, we can get some short-term gains to free up some of those resources for other important social goods, including primary care payments.
We want to thank each of you for this excellent dialogue. You know, we could keep going all the way through lunch, but I think they're going to be very angry with me if I don't break for lunch. So we want to thank you for your contributions. You've helped us cover a lot of ground today during this session, and you're welcome to stay and listen to the rest of the meetings as much as you can. At this time, we have a short break until 11:40 Eastern, and please join us then for a panel discussion from CMS and CMMI leadership, who will discuss their vision to achieve the goal of having all beneficiaries in accountable care relationships by 2030. We'll take a 10-minute break now till 11:40. Thank you.
Produced by the U.S. Department of Health and Human Services.